So I'm Jeff Olsen. I'm a radiation oncologist here in town at Washington University. I'm actually from Chicago originally, but came to St. Louis in 2003 for medical school and then stayed on for residency and stayed on after that on staff as faculty. Being here after 10 years, I have started to root for the local baseball team. So being from Chicago, I used to be a Cubs fan. But in any case, so I want to thank the Colon Cancer Alliance and the SNMMI for inviting me to speak a little bit about radiation for rectal cancer. You'll notice that I said radiotherapy for rectal cancer, not colon cancer, and I will go in a little bit to what are the differences between those, why is radiation used for one and not for the other, and talk just a little bit about kind of what one expects from a treatment, just because I know some people have never been through radiation, some people have. But just to kind of go through the whole process and why we do radiation treatment for rectal cancer. This is my disclosure slide. First, to kind of take a step back, if we say, what is radiation therapy? Kind of at its most basic level, radiation therapy is X-rays. So that's similar to when you have X-rays for a diagnostic test. Although the X-rays that you have for a diagnostic test are low-energy X-rays, whereas the X-rays that are used for radiation treatment are high-energy X-rays. Importantly, the target of radiation treatment is our cancer cells, or specifically the DNA of cancer cells. So by virtue of having high energy X-rays, it causes what are called breaks in DNA in cancer cells, and it prevents those cells from being able to grow. The effect of radiation is both on cancer cells as well as on normal cells, but as it turns out, normal cells can repair the damage caused by radiation, whereas one thing that happens to cancer cells when they become cancer cells is they lose the ability to repair the damage that's caused by radiation treatment. So that's actually why most radiation treatments are spread out over the course of a number of weeks. It basically, after each treatment, gives one to have a chance for their normal cells to repair the damage caused by radiation, whereas cancer cells can't repair that damage. One thing to kind of keep in mind that's an important point about radiation treatment is when we talk about cancer treatments in general, it's important to divide treatments into what are called local treatments, so treatments that affect a very specific area. Radiation treatment falls into that category in that it's a local therapy, so it affects where a tumor is specifically, but it doesn't affect if there were cancer cells in other places in the body, for example. So that's similar to surgery, but different from chemotherapy, which does fall under the category of systemic therapies. And typically for rectal cancers, as well as colon cancers, it involves some combination of local therapy plus systemic therapy, depending on stage and things like that we'll talk about. If we were to say, how is radiation therapy given? Just generally, there's different types of radiation treatment that you'll hear about, and there are different radiation machines that you'll hear about. If we talk about the biggest breakdown in categories would be whether radiation treatment is given through what's called external radiation or something called brachytherapy, which is internal radiation treatment. The main difference between those, with external radiation, the radiation beams come from the outside and are focused on a very specific point or a very specific area, whereas with internal treatment, it's radioactive particles that are typically injected, and those particles are given to where the tumor is. That sometimes there's a number of different techniques by which one can do the internal type of radiation. Most commonly, when internal radiation is done for colon cancer or for rectal cancer, it's something called radioembolization, which involves injection of small spheres into when there are cancer cells in the liver through something called the hepatic artery. And that's something I think we'll hear a little bit more about later on, but just generally, as far as a breakdown of the different general types of radiation treatment. One question that often comes up, so you'll see under that external radiation part on the left side, there's a whole bunch of different types of external radiation. So people may have heard about the gamma knife, general linear accelerator treatment, the cyber knife, or proton treatment. I think the important thing to know about those differences is that one unit of radiation is one unit of radiation regardless of how it's given. So the unit of radiation is something called a gray, just happens to be the radiation unit. And gamma knife or proton therapy or any of those types of radiation treatment, when deliver the same amount of radiation, there are specific situations in which one technique might be better at focusing the radiation treatment. So there's sometimes reasons to use one technique versus the other. But in general, one unit of radiation is the same regardless of the technique that it's given. So it's kind of, if you drive a car, if it's a Ford or a Chevy, it's still a car, but there are different situations in where there might be an advantage to one. When we think about rectal cancer treatment and kind of where does radiation fit in for rectal cancer treatment, just as far as a basic standpoint, if we talk about kind of the earliest stage of cancer, cancer stages are divided by kind of the tumor size and how much cancer is invading into nearby lymph nodes, and then if there are cancer cells elsewhere in the body. At the very earliest stage would fall into the category of what would be called a T1 or T2 without any involvement of nodes or anywhere else. Oftentimes surgery alone is a sufficient treatment, so no radiation treatment or no chemotherapy are typically required in that situation, although regular follow-up and screening is obviously very important in that setting. For tumors that are more advanced but limited to the pelvis, meaning that if a tumor is what would be called a T3 tumor or greater, or if there are lymph nodes nearby the tumor that are involved, that falls into a category where additional treatment is required, and that additional treatment often consists of radiation and often with chemotherapy as well. Oftentimes the standard course of radiation would be 5 weeks of radiation, although there are certain specific situations in which 5 days are sufficient. We'll talk a little bit about that. And then surgery 6 to 8 weeks after radiation. The reason for that delay is twofold. One, to give people enough of an appropriate time course to recover from the treatment, but also because how radiation works, even though it affects cancer cells quite quickly, it does take some time for those cells to shrink down and have a full response. We know that basically to give that time interval of 6 to 8 weeks after treatment, it allows for additional what's called downstaging or shrinkage of the tumor prior to surgery. And then depending on the specific situation, oftentimes if there are lymph nodes that are involved and seen at the time of surgery, the standard of care would be to continue with chemotherapy for about 6 months after surgery. So it's a long treatment course, and that's why whenever we meet people for the first time, there's a lot to talk about and a lot to sort out as far as the plan and what to expect from treatment. Finally, if there's cancer outside of the pelvis, so in the liver or lungs or elsewhere in the body, we know that chemotherapy is usually the most important treatment because it, again, gets back to that chemotherapy being a systemic treatment going throughout the entire body. There are very specific situations where radiation and or surgery are useful, but you can get into kind of a lot of hypothetical situations and a lot of kind of very specific scenarios, but in general, chemotherapy is the most important if there's cancer cells outside of the pelvis. If we say radiation therapy for rectal cancer, so you have to ask the question, well, why is it required? We're going to talk a little bit more about this, but the main reasons that we do radiation therapy for rectal cancer are first to shrink the tumor, and that has twofold. One's to increase the chance of having a successful surgery, so reducing the chance of what would be called a positive margin, or having cancer cells present at the edge of the rectal tissue that's removed. We know that it's helpful at reducing the chance of what's called a local recurrence, or having cancer come back in the pelvis. In that same kind of idea is sterilizing involved lymph nodes. And we do know that doing radiation before surgery has less side effects than doing radiation after surgery. So that's why the treatment is usually done before surgery as opposed to after. Why before surgery? So we know that there's also a reduced recurrence risk compared to treatment after surgery. So what this is there was a trial that was done in Germany kind of years ago, so it was a European trial, in which patients were randomized by the flip of a coin to either receive their radiation treatment before surgery or receive radiation treatment after surgery. And without going into too much of the trial, the graph on the upper right side is kind of a comparison of doing radiation treatment before surgery with radiation treatment after surgery. And on the y-axis, that's the chance of having cancer recurrence, and on the x-axis is time. So you'd rather be as close to the x-axis as possible, meaning no recurrences. And we know that from the two arms, the arm on the bottom was doing radiation before compared to after surgery. So that's generally why radiation is done before surgery. Secondly, in that same study, they looked at the chance of what's called having a sphincter-preserving surgery. Now, this isn't always a possibility, so what a sphincter-preserving surgery refers to is being able to not have ostomy after surgery. And I think taking a step back, the most important thing is to make sure the cancer is removed in its entirety. So oftentimes an ostomy is required, but we know that in cases where a tumor is kind of borderline, where the surgeon says there's a chance, but I don't know for certain. In this trial, they looked at this, and as it turned out, in the group of patients that had radiation treatment before compared to after surgery, there's a greater proportion of patients who ultimately were able to undergo what's called the sphincter-preserving operation. So that's kind of a second reason that treatment's given before surgery. A question that often comes up and is important is how many treatments. So basically the basics of treatment are that they happen daily on a Monday through Friday basis. Each treatment is about 20 minutes. The total number of treatments depends on the specific situation. Most commonly, it would be a total of 28 treatments, so for about 5.5 weeks, and with that longer course of treatment, it's usually given at the same time as chemotherapy. Occasionally, one can do treatment in just a 5-treatment course, so a total of 5 treatments, Monday through Friday or Wednesday through Tuesday the following week as the schedule may determine. How do we pick 5.5 weeks or 5 days of treatment? Well, in general, we look at and ask the question, is significant downstaging required for surgery? So we have a discussion with the medical oncologist and a discussion with the surgeons at our tumor conference that happens once a week. And in cases where there's a tumor that the surgeons have concern about, where they say this is a situation where we really do need to have a lot of shrinkage of this tumor before surgery, typically a 5.5 week course of treatment is recommended in that case. Whereas if it's a situation where it's kind of lower risk, where the tumor is smaller or a little bit higher up in the rectum, where it's more accessible for surgery, oftentimes we can consider a 5-day course of treatment, but that does kind of vary on the specific setting. All treatments are generally outpatient, so patients generally drive to and from treatment. And obviously one can be inpatient if needed, but people generally tolerate these treatments well enough that they don't feel sick where inpatient is required. And for a 5.5 week course, again, as I mentioned, kind of what's called a radiosensitizing dose of chemotherapy is given, basically a low dose of chemotherapy that makes cancer cells more likely to die in the setting of radiation is given at the same time as treatment to make the treatment more effective. So if we say, how is radiation planned? Well, there's a couple of steps that go through the planning. The first step is something called immobilization, or basically doing a planning session to kind of generate a treatment plan for radiation. What's done is a mold is fitted to the body, so people usually lie on their stomach, and there's a pillow that you can't see here, but that actually presses up into the pelvis area to help push a lot of the normal intestines up out of the pelvis, so to kind of push a lot of the normal tissues away from where the radiation is going to go. And that mold is fit on a patient-specific basis. There are other types of radiation treatment where there are other types of molds that are used. So in the lower left corner, that's a different type of mold that's used for a different type of treatment, but all have the same general idea. And that idea is at the time of planning, we want everything to be in the exact same position on every day of treatment as things are at the time of treatment is planned. So a lot goes into that first day of planning to make sure that things will be reproducible and everyone will be in the same position from one day to the next to the next. Once that mold is made, one does what's called a simulation, which is a CT scan to basically help out plan the treatment. That CT scan itself is very similar to a diagnostic scan. So the scanner itself is very similar, but there's a couple differences in the room. This room has kind of lasers that are in different points in the room that help us mark out the positioning relative to the scanner. And those kind of same localization aspects are the same that are in the treatment room. So it lets us line everything up in the exact position on the exact same spot from one day to the next. Once we have that scan done, one does what's called treatment planning, which is basically draw out a radiation target. So first we draw out where the radiation needs to go, but also importantly where the radiation needs to avoid. And there's actually people who work in the department who are trained dosimetrists, so dosimetry school is typically about 2 years, and one goes through school to be able to generate plans based on where the radiation target is and the exact location of where treatment needs to go and where treatment needs to avoid. This is just an example of a rectal cancer treatment plan. So typically for rectal cancer, there's 2 volumes. There's a lower dose volume, which includes both the tumor itself and the rectum around the tumor, but also the lymph nodes that are nearby the rectum. And then there's a higher dose volume that includes the tumor itself plus a small margin on the tumor, and where the tumor is specifically in the rectum or where the cancer started in the rectum receives a bit of a higher dose compared to the lymph node areas that we often know are at risk for having cancer cells, but usually we don't know with certainty, or certainly there's a lower volume of disease than in the tumor itself. What we see here on the left side is kind of those different volumes. So the red is the boost or the higher dose volume, and this is if you can see here, this is a CAT scan, so anything on this scan that's bone is white. So those white areas in the center are the pelvic bones. And as it turns out on this scan, so the patients for this type of scan lay on their stomach, so the rectum is kind of at the top of the scan, and the rectum itself is kind of outlined by that red contour, which is the boost volume. So once we define kind of the radiation target, so the high dose and the low dose target, that goes through treatment planning. So we kind of focus the radiation where it needs to go and where it needs to avoid, and then a lot goes into evaluating the plan to make sure that the radiation dose is covering the tumor, but it's not going into normal intestines or bladder or tissues like that. The different colors here, so you see the green color in the center, and then that purple color, and then the blue color, those are what are called isodose lines, which if you think about it, it's kind of like a topography map, where instead of showing elevation, it shows radiation dose. So we want there to be sufficient radiation dose where the target or where the tumor is, and then we want that dose to drop off quite quickly as you get away from that area. If one looks at kind of a regular X-ray, where are we treating? So this is a kind of what's called a plain film or a reconstructed X-ray, but it basically, if you can recognize on the right side, it's as if a film is shot from the front of a person, so you can see the pelvis there, and then in the center at the top are the vertebral bodies and the hips on each side of the film. And on the one on the left side of the screen is as if it's shot from the side, as you can see kind of the tailbone at the very back there, and kind of in the middle of this you see those orange and red targets, and that's a typical radiation target for rectal cancer. So the lymph nodes in the pelvis, which are those orange volumes, go to that lower dose volume, and then where the tumor is, in this case kind of lower down in the rectum, goes to a higher dose, and that's in that red volume. So once a plan is made, and once we have kind of a good plan for the treatment itself, that's when the treatments actually start. This is a picture of a linear accelerator, or one of the machines that are used for radiation treatment. And so a person would come in each day and be in that same mold that was made at the time of planning, again, to make sure that everything's in the exact same position. And this machine rotates around into different positions, staying about a yard away at all times, and focuses the treatment specifically to where it needs to go. So again, based on how that plan was generated. And then that happens each day. The treatments themselves, I mentioned, are about 20 minutes, but most of that time is actually spent lining everything up and making sure everything's in the exact same position for each treatment. So each day before treatment, one thing that we always talk about before these treatments are started is to know what to expect. Well, each day before treatment, X-rays are taken to make sure we compare the position on the day of the treatment with the positioning on the day of simulation or that planning session, and everything's lined up to make sure there's no change in position. So this, on the left side there, it's a low-quality CAT scan, which is kind of overlaid with that CAT scan that one would do on the day of the treatments are planned. And as you see here, it looks very similar, like it's almost the same scan, because everything is in the same position from the day of the treatment to when the treatment was planned. Side effects during radiation treatment. So if we were to say for this, I guess if we take a step back, importantly, side effects are different based on the different type of radiation treatment. So one thing that we always kind of talk about when we meet people for the first time is that side effects for a course of rectal cancer are different than side effects if anyone had a family member go through breast cancer or other types of cancer. With rectal cancer or pelvic radiation treatment, certainly the common types of side effects during treatment are tiredness or perhaps having diarrhea, or the side effect that usually causes the most bother or most discomfort is effect on the skin. So because of where the rectum's located, it's impossible to do the treatment properly but not have some radiation dose that goes to the skin. And the skin in the area around the rectum does tend to be a more tender area, so that's something that we always see everyone at least once a week over the course of treatment. Make sure we're doing our best to stay ahead of those with medications and creams applied to the skin if needed. Things that are much less common are things like nausea or urinary symptoms like hesitancy or discomfort during radiation treatment. But importantly, things that are unlikely or never from radiation to the pelvis would be having hair loss, so that doesn't happen with radiation treatment. If one has hair around the rectum area, that hair will be lost, but you don't lose hair on your head from radiation treatment. Likewise, being radioactive during external treatment, so there's no risk to family or small children or pregnant women, things like that. That is something we have to talk more about with some of those other internal types of treatment, but with external radiation, one doesn't become radioactive. Importantly, there's a separate set of side effects that we always talk about that can happen after radiation. So these are all things that happen or don't happen during treatment, but there's a separate things that the risk of which we make as low as possible with planning out the treatment, but there is always a risk of having radiation scar tissue form in the months or sometimes even years after treatment. And those are things that in kind of planning out the treatment, there's always a risk of, for example, having an ulcer or in the worst case, having a hole form sometimes in tissues. But that's something that we saw a lot more with kind of prior ways that radiation treatment was planned. With the current modern techniques, the chance of having those more severe side effects is much less in the single digits. But those are things that, because obviously that does happen occasionally, we always make sure to talk about it kind of at length when we're planning out a treatment. So what happens after radiation treatment? So one gets to the last day of treatment. The side effects of radiation are cumulative, meaning each day one doesn't feel anything different during treatment, but gradually over the course of weeks of treatment, you start to notice perhaps more of those tiredness or effect on the skin. After one finishes the treatment, in the weeks after finishing treatment, those side effects gradually improve. They don't happen right away because there is a time lag from when a treatment's given to when one has the effect of the treatment. So the effects of the last week of radiation treatment often would carry into the first week after treatment. But then the effect on cancer cells continues for about 2 months after the end of treatment. So when we talk about that 6 to 8 week waiting window before surgery, that's why we have that waiting period, so that treatment continues to work. And then at that point is when one would plan on usually doing the definitive surgery. So briefly, what about colon cancer? So colon cancer is different. There's a lower risk of what's called local recurrence for colon cancer, meaning that if a colon cancer comes back, it tends not to come back in the exact same spot as where it was removed. Generally, for colon cancer, because of that reason, often for earlier stage disease, surgery alone is sufficient, or for more advanced stage disease, just because of the risk of where a cancer tends to come back, oftentimes after surgery, chemotherapy as opposed to radiation therapy is given. There's a couple exceptions to that. So radiation is sometimes used in a few situations. One is if one has a very advanced tumor, so a tumor that's growing into organs nearby the colon. We'll sometimes consider radiation to try and shrink that prior to surgery, in particular if the surgeons feel that it's going to be a very challenging resection, that there would be a benefit to shrinking or downstaging. And second is in what's called internal treatment, or what I talked earlier, that internal type of radiation treatment. That's most commonly done in colon cancer if there's specific involvement of the liver, and oftentimes the liver only is when one would sometimes consider that internal type of radiation to deliver a focused dose of radiation to cancer cells in the liver. And lastly, and this is true not just for colon cancer, but other types of cancer as well, if there's a specific area that's causing symptoms or a very specific problem, oftentimes a shorter course of radiation can be given, that shorter course to have less side effects, but with the idea of helping out with symptoms from a tumor in a given position. That's most common if a cancer is involving the bones somewhere, or if it's somewhere that's causing bleeding. Radiation treatment can often be a very effective treatment to help with those problems, but without, in many situations, causing a lot of side effects because of the lower dose that's used in those circumstances. So I think that's in kind of a little bit of just an overview about treatment, what to expect from treatment, and why we do certain things about treatment.